only, Brooke, it feels like longer.
Pardon?
Is your internship only a year?
Yeah.
Feels like ages.
Yeah.
You finished? Have you?
Yeah, on Friday.
Oh, congratulations.
Yeah.
Amazing.
Yeah.
So Brooke has essentially been doing an intensive cardiology training program over the last year and has been sort of, I think, working, this is a presentation that Rita gave originally and Brooke's
Revamped.
Brooke's working on it. So this is a pretty high level ECG. So we're in our listeners, we've got a group of kind of membership level GPs and in medicine interested GPs and interns and residents. So there's a bit of a range of backgrounds. So it's an interactive, we usually do this quite an interactive program. So Brooke, you have people to jump in with questions as we go.
Yeah, sure. That's fine.
Super. Excellent.
Awesome. Let me just figure out if that.
And we also,
slide.
I was going to say, we also record, Brooke, if that's okay, and anyone that couldn't attend can look back on the video.
Sure, that's fine.
Super.
Easy.
We can see it.
Can you see my screen yet? Does that work?
Yeah, that's perfect.
This says the ECG, it's not as hard as you think.
Yeah.
Okay, cool. Because I can see like all of you guys, and I'm not sure what your view of my presentation is. Cool. All right.
I think we've got you down in the corner, but I think we've got your camera off.
Oh yeah. I'm in my room in my pajamas still, so I'll probably stay off with that.
Stay off.
It's my day off, and I've got to run off to get my my vaccine booster after this. But
well, thanks for doing this. Much appreciated.
That's okay. All right. Is everyone here for me to start?
Yeah.
Alrighty. So, yeah, my presentation is on arrhythmia. So the ECG, it's not as hard as you think. And I guess when I first started my internship about a year ago and Rita started handing me ECGs and saying, write a report on this, it was pretty terrifying. And I can understand why vets do find ECGs a little bit tricky. So we're just going to go through a lot of the common arrhythmias and things that we see and techniques on how to obtain a good ECG and read and interpret ECGs. Maybe a bit of review for some people, but for other people, at least hopefully everyone will learn something from this presentation. So we'll start with just talking about the electrical system of the heart. The heart is composed of muscle fibers with a coordinated conduction system, and this system consists of the sinoatrial node, the internodal atrial pathways, which involve the anterior internodal tract, the middle internodal tract, and the posterior internodal tract, and the AV node, the bundle of His, the right and left bundle branches, which then divide into the anterior and posterior fascicles of the left bundle branch, and of the bundle branches, and then the Purkinje system. Let's see if that works. Cool. Early investigators discovered that the beating heart was stimulated to do so by electrical processes and found that body fluids are really good conductors of electricity. Back in 1887, Augustus Waller used his own bulldog, pictured on this slide, called Jimmy, to demonstrate the first ECG, which you can see on the left-hand side as a trace, showing that these electrical impulses could be recorded from the surface of the body. So this, the figure on the left of the screen is one of Waller's original electrocardiograms using his little dog Jimmy, a sort of primitive capillary electrometer. It was then a guy called William Enthoven who introduced the labels P, Q, R, S, and T for the various deflections that you can see on the ECG. So the ECG is simply a recording of that wave of electrical activity as it spreads through the heart. This is the mean wave of depolarization for a mass of individual cells. So when a muscle fiber is stimulated, a wave of depolarization passes over or across the cells, and the ECG will record an upward deflection if the depolarization wave flows towards the positive electrode of the ECG, and a downward negative deflection if it flows towards the negative electrode of the ECG. So talking about, sorry, my silly mouse isn't working, the standard bipolar leads. So these are the standard limb leads that you can see up here in the left side of the screen. They show the activity of the heart from two directions. So lead 1 depicts the wave of depolarization in the direction from the right arm to the left arm. The right arm is the negative pole, and the left arm is the positive pole. In lead 2, it depicts the wave of depolarization in the direction from the right arm to the left leg, which is the base orientation of the heart, and the right arm is the negative pole and the left leg is the positive pole. So generally, normal electrical activity is towards that positive pole or the left leg. So we normally see a positive deflection. Lead 3 depicts the wave of depolarization from the left arm to the left leg, and the left arm is the negative pole, the left leg is, the negative pole, and the left leg is the positive pole. Then the augmented limb leads, these use the same electrodes as those to record the standard bipolar leads, but they're now recording it in different combinations so that we can see the electrical activity, from 3 different angles, or 3 new angles. So lead AVR simply depicts the activity from the right arm to a point that's between the left leg and the left arm. Lead AVL depicts the electrical activity from the left arm to a point between the right arm and the left leg. And lead AVF depicts the electrical activity from the head to the tail, basically, as you can see in this picture. And these augmented limb leads in combination with the bipolar leads make that standard 6-lead ECG that we often talk about, and are useful for determining the mean electrical axis, which I'm about to talk about as well, or position of the heart for confirming information obtained from the other leads. So while a cardiologist like Rita will look at every lead on the ECG, most of us are more familiar with looking at lead 2, and certainly when I'm interpreting and reporting, I start by looking at lead 2 as well. So we'll concentrate on that for a moment, remembering that lead 2 depicts that wave of depolarization from the right arm to the left leg. In this orientation, the P wave depicts the right and then the left atrial depolarization initially, and the normal wave of activity moves towards lead 2. So hence, the P wave is a positive deflection in lead 2. All the cells must then repolarize in order to be stimulated again. And the atrial repolarization is usually not seen on the ECG because it's buried in ventricular depolarization. The ventricular depolarization is depicted by the QRS complex. Oops. There we go. The Q depolarization force is the first directed towards the right bundle branch and away from the positive pole of lead 2, resulting in a negative deflection in lead 2 in the Q wave. By convention, the Q wave is always the first negative deflection, and there may or may not actually be a Q wave when looking at your ECG. The first positive deflection is the R wave. So the conduction system branches subendocardially within the apex and 3 walls of the ventricles simultaneously, depolarizing from the endocardium towards the epicardium. And because the mass of the left ventricle exceeds that of the right. As we know, the left side of the heart's a lot thicker. There's the leftward forces predominate and spread the impulse towards the left, which is the positive electrode on lead 2. And so obviously we're going to see a positive R deflection, and then by convention, the S wave is that second negative deflection. So the free walls and the septum are the last parts of the ventricle that are activated. And as the depolarization wave moves away from the positive pole of lead 2, we see a negative S wave that's recorded on our ECG. And then we get repolarization of the ventricles, which is the T wave. And this can be either positive or negative in the dog or the cat, and starts at the epicardial surface of the ventricle and then spreads towards the endocardium. So the mean electrical axis, for some reason, this word seems to instill fear in most vets that I know. As discussed in the previous slide, the activity of that heart produces simultaneous many potentials of it in many directions in the three-dimensional field. So the electrical axis simply refers to the average direction of this activation of electricity. Using the 6 limbs, six leads, 1, 2, 3, AVR, AVL, and AVF at different angles, you can record the heart's electrical activity and you can estimate that mean electrical axis. You can't estimate this if you're just using the basic 3 leads. So you do need a proper 6-lead ECG in order to estimate the mean electrical axis. I find the simplest method to be to plot the polarity, so that whether it's positive or negative in 2 perpendicular leads, and generally I use lead 1 and AVF, and the most easy to remember. Both one dog out in the next slide. Dogs middle slide is positive. And if the axis becomes less than 40 degrees, it's called a left axis deviation, which would indicate left ventricular enlargement. And if the axis becomes greater than 100, it indicates a right axis deviation, which would mean the right indicates right ventricular enlargement. In cats, they have a bigger or a wider mean electrical axis, as you can see in the picture on the right-hand side. Their normal heart axis is between 0 and 160 degrees. And similarly for the cat, if the axis becomes less than 0 degrees, we get a left axis deviation. And if it's greater than 160, then it's considered a right axis deviation. And these abnormalities suggest either left or right ventricular enlargement, respectively. The mean electrical axis becomes less important with our increasing use of echocardiography, which can tell us definitively as to the presence or absence of chamber in wasn't available. It was amazing how much a thorough exam and a good quality 6-lead ECG and X-rays could be used to diagnose things. In the electrical axis of lead 1 is taken as 0 degrees towards the left, and plus or minus 180 degrees towards the right if it's negative. And the axis of AVF is taken toward 90 degrees and negative 90 degrees. The QR amplitude of lead 1 and AVF along the corresponding axis, depending on what direction they are. And then the resulting between those two is calculated as the mean electrical axis. So indications for using in the ECG. The ECG is a really useful tool for 2 major areas, either diagnosing heart arrhythmias or providing information on the status of the myocardium. Some important indications evaluation of tachycardia, bradycardia, or an arrhythmia heard on auscultation, acute onset of dyspnea, shock, fainting or seizures, cardiac monitoring during or after surgery, sometimes preoperatively in older animals, cardiac murmurs, although echo is probably more informative than an ECG for those, cardiomegaly found on thoracic radiographs, cyanosis certainly can result in cardiac arrhythmias, evaluating the effect of cardiac drugs such as digoxin, quinidine, calcium channel blockers, and beta blockers, for monitoring the location of a needle during pericardiocentesis, if you're performing that, systemic diseases that can affect the heart, so GDVs, pyometra, uremia, and pancreatitis, all of which can affect your ECG. And as we probably already know, electrolyte disturbances, especially those of potassium, can impact your ECG. So limitations, it is important that you interpret the whole clinical picture when interpreting an ECG. So always consider the entire clinical picture. The ECG tells you nothing about the mechanical status of the heart. So an animal with severe cardiomegaly and congestive heart failure can have a normal ECG. And an animal with a structurally normal heart can have a very abnormal ECG as well. So we can't necessarily use that to make a diagnosis. It doesn't record pathology of the heart valves, coronary arteries, endocardium or pericardium. It only gives you information about the myocardium. So it's essential to know these limitations. The division between the normal and abnormal is considered a pretty broad zone rather than a sharp line. So don't read too much into borderline changes you may see on an ECG. There is also wide variations depending on body conformation in breeds of dogs that may alter a little bit the accepted standards of measurements. So you need to take into account if you have a very small or very, very large dog when making your measurements of an ECG. And most importantly, and I'll talk about it again in a minute, is the ECG must be recorded properly. It must be complete with a stable baseline in order to be accurately interpreted. So this is just some pictures of the ECG machine that we use with our service. It's just a small machine that Rita bought from Amazon or eBay. They're quite inexpensive. They're usually human machines that we use in animals. There's generally a screen where you can see your ECG trace before printing it out. And there's an option to change things like speed and sensitivity on there, to put in patient data information and select that you're wanting a 6 lead, which is a usual standard in veterinary ECG, rather than the 12 lead that they commonly use in people. And there are a few different attachments available. You can either use little ECG dots and clamps, or we use these little soft, gentle clamps and apply gel and alcohol directly to our patient's skin. So when attaching an ECG, it is really, this is like super important that it's done in the correct fashion, because it really impacts your interpretation. So the right hind leg needs to be on the ground. We often get ECGs sent to us for interpretation that have so much movement on the baseline that we really struggle to interpret anything that's going on at all. And it is essential to restrain the animal in that right lateral recumbency every time. And this is for 2 reasons. A standing, moving, and trembling animal produces too much baseline artifact, no matter how they're standing. And the second reason is that the reference ranges for measurement of our complexes are derived from a dog or a cat in right lateral recumbency. So they do need to be positioned correctly if you're going to make your measurements and interpret them compared to standards reference ranges that we have for dogs and cats. The only exception to this rule of right lateral recumbency is the marked dysmic animal. Obviously, in this situation, immediate ECG isn't usually a major priority anyway, but if it's deemed that an ECG really is needed, the position of the patient, whatever they're most comfortable in, will suffice, and you can get a more accurate ECG at a later date when the animal is more stable. They do need to be placed on a non-conductive surface, so a metal table is no good. It will need to be covered with a rubber mat. The ECG clips can be placed anywhere on the limb, so we generally place them where there's a good amount of loose skin, and to minimize trembling and panting artifacts as much as possible. We put them as far away from the elbow and the stifle as we can, so we go more distally on the limbs as possible. We wet the skin with alcohol or electrode coupling gel, usually both, to ensure really good contact. So there's some tips on how to get a good ECG, and this is just a picture of a patient that those ECG leads are placed quite high on the elbow. So if that animal was trembling, we'd sort of find some looser skin further away from the elbows and the knees to try to get rid of some of the movement artifact if that patient were shaking or panting heavily. So my approach and Rita's approach that she's taught me to the ECG is how we characterize and report every ECG that we interpret. So the ECG on this slide here, the paper speed is set at 25 millimeters per second. So the time between the lines at the bottom of the page is 1 second. So we would report this particular ECG as follows. The heart rate was 200 beats per minute and regular. So we'd count the number of complexes in 3 seconds and then times that by 20 to get that heart rate of 200. There were P waves for each QRS complex and vice versa. The QRS complexes were narrow and upright, consistent with a supraventricular origin. So the diagnosis for this is most likely a sinus tachycardia. And a nifty little piece of equipment that I pretty much needed to get from the beginning of my internship was a pair of these ECG calipers. I use mine pretty much every single day at work. I purchased them for $11 from Med Shop online, and they're the best thing that I bought all year. And I don't think that you can actually properly interpret an ECG unless you have a proper pair of these calipers to make your measurements, to ensure that when you're measuring your complex sizes, your PR intervals, your QRS amplitudes and so forth, that you're able to do that accurately. It's quite hard without a pair of these. So if you are going to be doing interpretations, I would strongly recommend getting some calipers. This slide just talks about some of the common artifacts that we see. So it is important to remember that the ECG is a mechanical recording. So any number of technical or mechanical problems can occur. These problems will be superimposed on the cardiac complexes and may interfere a little bit with interpretation. Hence, it's really important to be aware of what these common artifacts look like. So firstly, electrical interference. This will appear as a regular sequence of, and you'll see it down here, the 60 cycle interference of 60 sharp up and down waves per second. Hence the common name 60 cycle interference. If it's severe, the ECG can't be interpreted. So the cause needs to be found and eliminated. Possible sources for this interference include lack of proper grounding of the power cord to a 3-prong wall outlet. So this will ground the ECG automatically, while a 2-prong power outlet cord wouldn't. That's something I have learned. Reapplying the electrode clips, making sure that they are securely attached to the skin and the clips are only dampened and not saturated with alcohol. Making sure the clips are clean and securely attached to the cables so that there's not any of them that are loose. And pulling the plug on any other electrical equipment that's close by. That's something else that I've learned when we can't get a good ECG chase, is that sometimes there's electrical interference by close equipment, turning off of fluorescent lights. These don't even have to be in the same room to impact your ECG. So there are things to think about if you're getting a lot of this interference in your trace. Making sure that the animal's legs are held apart. So Lucy will usually hold the back legs apart and I'll hold the front legs apart, or vice versa, and making sure that the holder isn't touching any of the clips inadvertently with their hands or arms. And if you're using a metal table, making sure that there's a rubber mat between the patient and the table and all of the cables, and that no part of the leads or the animal is touching the metal, because that will result in a lot of artifact. Muscle tremor is another common artifact, and it's just due to simple muscle trembling, panting, or purring, and sometimes maybe impossible to get rid of this artifact. So it needs to be taken into account when trying to interpret your ECG. Try to make sure that the dog or cat is as comfortable as possible. We generally have them on a nice padded ECG, not ECG, our echo pad. Sometimes you'll gently blow on the face to stop a cat from purring, or turn on a tap or something to distract them. And sometimes we'll also have the owner in the room and place a hand on the chest to or reapply the electrodes to make them as comfortable as possible if they're causing the patient some discomfort. Reducing the amplitude to half sensitivity can also help reduce a bit of artifact, enough to make the ECG more interpretable. And occasionally mild sedation may be needed, but again, this needs to be taken into account when interpreting your ECG. That said, for most cats who we see that need an echo and an ECG, we will always sedate them with some butorphanol in order to perform both these procedures, as they often don't just tolerate, they'll only tolerate one, even if they're a nice cat. The example down the bottom is a wandering baseline. This is usually due just to respiratory or general movement. It will usually resolve itself as the patient settles. And again, make sure they're as calm as possible and as comfortable as possible. So generally when we start our ECG trace and we're seeing it on the screen, we always see a wandering baseline. We just wait for that to even out before we start to print out our ECG. And this is just an example of the kind of ECG that we get sent and asked to interpret almost every day. We can't really tell for sure what this arrhythmia is either. It's quite light. There's a lot of wandering baseline, and there's a lot of baseline artifact as well. So if panting, move the leads away from the chest to the distal limbs, making sure that you've applied alcohol or coupling gel to get the best contact and have the patient as calm as possible. Wait for the ECG machine to sort itself out. So it might be if you just let it run for a couple of minutes that will straighten up. And also a low stylus heat or a dirty stylus can make the QRS complexes difficult to see. So in this, it's quite a light trace. So increase the heat on the stylus. For those of you who don't know, ECG isn't printed ink. It's paper that's sensitive to heat, and it's the heat that changes or creates that trace that we see on the paper. So increasing the heat on the stylus or cleaning it will result in a trace that can be seen. So if you're having trouble, that's something that you can fiddle with on your machine if you have one. And I'm not going to lie, cat ECGs are really hard, mainly, and I hate it when Rita gives me a pile of cat ECGs to report on, mainly because the P waves and QRS complexes can be so small often due to the fractious nature of the species. We only get a short window in order to get a good trace. So there are still some cat ECGs that myself and Rita find quite difficult to interpret. And in the cat, due to the small size of the complexes, it is doubly important to make every effort to obtain a clean trace. We usually increase the sensitivity from the standard 10 millimeters per millivolt to up to 20 millimeters in this species, just to make it a little easier to see the P waves. That's a hot tip. All right, so into the arrhythmias. This is an irregular sinus rhythm which originates from the sinoatrial node. You can see alternating periods of slower and more rapid heart rates in a regular pattern. And this is related to respiration. So the heart rate increases with inspiration and decreases with expiration. This is a normal finding in the dog and is due to changes in vagal tone and thoracic pressure changes with inspiration and expiration. Often accompanying this, although not on this trace, is a wandering pacemaker. And And this is an increase in the P wave amplitude as the heart rate speeds up and down. Again, it's due to changes in vagal tone affecting the region between the sinoatrial node, and that stimulates the initial beat. So sinus arrhythmia is an unusual finding in a cat in a hospital setting, but it has been shown in a 24-hour Holter monitor in a cat that they do actually have sinus arrhythmia as well while they're relaxed at home. And this arrhythmia can be abolished by exercise or atropine, which blocks the vagal input, producing a sinus tachycardia in the normal dog or cat. Bradycardia, so we consider anything less than 60 beats per minute in the dog and 140 beats per minute in the cat to be bradycardic when in a hospital setting. It is an important point, as if you ever have seen Holter monitoring, it is common to see the heart rates of dogs down at 30 and cats 60 to 80 beats per minute when they're in a deep sleep. So if you're ever seeing a Holter and the heart rates of those low, that is normal and doesn't require any treatment. However, the heart rate should increase appropriately when the animal is active, and if this doesn't occur, then there is a problem. So causes of bradycardia include sinus bradycardia, sinoatrial block and sinoatrial arrest, sick sinus syndrome, atrial standstill, and the AV blocks, so first, second, and third degree AV block. And we'll go through each of these individually. So sinus bradycardia. This is a normal sinus rhythm that is considered slower than appropriate for the situation, and it can be due to things like increased parasympathetic tone, so high vagal tone due to ocular, GI, chronic respiratory, systemic, or CNS disease. Quite commonly in the otherwise healthy animal, despite extensive searching, we fail to identify an underlying cause. An athletic animal can have a sinus bradycardia. It can be seen with a GA overdose, impeding cardiac arrest, hypothermia, so maybe post a prolonged general anesthetic. Severe hypothyroidism can also result in sinus bradycardia. It can form as part of sick sinus syndrome. Certain drugs such as digoxin, beta blockers, and calcium channel blockers can result in a sinus bradycardia, and early hyperkalemia can as well. Treatment's rarely required. We usually all that you need to treat is the underlying cause. If severe atropine may be required while the underlying cause is being found and treated. So sinoatrial block and arrest. Sinus arrest is failure of the impulses to be formed in the SA node due to depressed automaticity in the node. So SA block looks similar to sinus arrest, but the transmission of the regularly formed impulse from the node is blocked from entering the atrial myocardium. So differentiating between these two can be quite difficult. The rhythm is regularly irregular and may look like an exaggerated sinus arrhythmia, with pauses showing complete absence of PQRS and T complexes. The pauses are twice or greater than the normal RR interval. So you can see on the example above. If the pauses are long enough, a junctional or ventricular escape may occur. This arrhythmia is again often due to high vagal tone, and if this is the case, it will be abolished by atropine. Pathological causes include conditions of the atria such as dilation, so really, really big atria, fibrosis, neoplasia, or sick sinus syndrome, which we'll talk about in a second. And these generally have no or partial response to atropine. So in this example here, the paper speed of the ECG is 50 millimeters per second. The first two complexes occurring at an instantaneous rate of 100 beats per minute. And then there's a 2-second pause. Then you can see there's this ventricular escape beat, which is at a rate of 30 beats per minute. And then there's a mild tachycardia at 150 beats per minute. So the normal rates of the various parts of the heart are important to remember. So the sinoatrial node conducts between 60 to 220 beats per minute, the AV node at 40 to 60, and a ventricular myocardium at 20 to 40 beats per minute. So sick sinus syndrome is the most likely diagnosis for this ECG versus high vagal tone, and how we would differentiate between the two would be an atropine response test. Sick sinus syndrome is due to disease, usually fibrosis of the sinoatrial node. It is commonly referred to as sick sinus syndrome, but it's not uncommon in advanced cases to see disease of the lower pathways. So the AV node and bundle of his and right and left bundle branches can be impacted as well. It commonly results in bradycardia with long periods of sinus block or sinus arrest. And in the ECG that you can see, this 2-second pause has been broken by that ventricular escape beat. The other common cause name that you may read about for this particular syndrome is tachycardia bradycardia syndrome, due to periods of bradycardia interspersed with runs of APCs or SVT. But we rarely actually see that form of disease. It usually presents purely as a bradycardia. And when trying to differentiate this type of an ECG due to high vagal tone, as I said, we do the atropine response test. When using atropine in the cardiac patient, we use the maximum dose of atropine, so 0.04 mg per kg, IV or sub-Q, because we want to know for sure if atropine is or isn't going to work. So it makes no sense to go with a lower dose. We usually do the dose subcutaneously and then recheck the ECG 30 minutes later. If you're doing it IV, keep the ECG on the patient and continue to check it for 5 minutes to look for a response. A complete response to atropine is by definition a heart rate in a dog that's greater than 160 beats per minute with a regular sinus tachycardia. And anything less than that could be termed a partial response, or if there's no change at all, then we say it's no response. If it has no effect, then protenerol, a pure beta agonist, dopamine, dobutamine, or cardiac pacing may be required. Due to disease of the sinoatrial node, sick sinus syndrome is often poorly responsive to atropine. So if the animal is clinical, so having weakness or syncopal episodes, some time might be bought with anticholinergic or sympathomimetic drugs. But generally, this condition usually, the response usually wanes over time, and permanent pacemaker implant is the only definitive treatment. So the AV blocks, this is an example of first degree AV blocks. So the ECG is at 25 millimeters per second. The PR interval is 6 boxes, so 0.24 seconds. And that by definition is a delay in the PR interval. So first degree AV block is a delay or interruption in the conduction of the supraventricular impulse through the AV junction and the bundle of His. There are 3 types of AV block: first degree, second degree, and third degree. In the first degree AV block, the P waves and QRS complexes look normal, like in this ECG, but there's that delay in the conduction resulting in a prolonged PR interval, which is greater than 1.3 seconds in the dog and greater than 0.09 seconds in a cat. The most common cause of first degree AV block is high vagal tone, in which case the abnormality should be abolished by giving atropine. If atropine doesn't abolish, whoops, where's my mouse gone, abolish the block, then an early AV nodal bundle of His degeneration is likely, and it may progress to a higher grade of AV block eventually. There are some drugs that affect conduction through the AV node that can cause first degree AV block, which include digoxin, beta blockers, and class 1A antiarrhythmics, so quinidine, for example. Second degree AV block. This is characterized by intermittent failure of P waves to conduct through the ventricle. So one or more of the P waves are not followed by a QRS and T complex. There are 3 types of second degree AV block. So Morbis type 1, type 2, and high grade second degree AV block. So type 1 is characterized by a progressively elongated PR interval until the P wave is blocked. So that's the example here on this ECG. So the PR interval here is quite short, and it's getting longer between each of these complexes until finally there isn't one. The most common cause of this is high vagal tone, and it should be abolished with atropine. Morbus type 2 is the next one. So in this form of secondary AV block, the PR interval stays consistent between each of the QRS complexes, and we will see the loss of a QRS complex intermittently. This is more likely due to AV nodal disease such as degeneration, fibrosis, inflammation, and ischemia. So it's less likely to respond to atropine. And there is hereditary stenosis as well. So this is an example of high-grade second-degree AV block. There are never two P waves conducted in a row, and that is by definition a high-grade secondary AV block. It often occurs in a fixed pattern, so 2-to-1, 3-to-1, 4-to-1. In this ECG, there is 3-to-1 to 4-to-1 high-grade second-degree AV block. So this is 3 before we get a QRS complex. Here is 4 unconducted P waves before we get a QRS complex. It is almost always due to AV nodal disease. It may result in exercise intolerance and syncopal episodes, and it will usually eventually progress to third-degree AV block. It's usually not responsive to atropine, although we'll still always try it. And permanent pacemaker implant is the only treatment option for a patient with a high-grade second-degree AV block. And then third-degree AV block is complete heart block. It refers to an AV block where there's no P wave ever conducted through to the ventricle. To avoid death from ventricular asystole, the ventricles assume their natural pacemaker activity, which we talked about before is normally between 20 to 40 beats per minute. However, sometimes you can get a junctional escape tissue taking over the pacing of the heart, and this can occur at a faster heart rate of around 40 to 60 beats per minute. So they're not always as slow as 20 to 40 beats per minute. The most common cause of this is idiopathic fibrosis of the AV node. There are other reported causes, which include congenital AV block, so that's stenosis of the bundle of His, as reported in pugs that I mentioned, and other structural congenital diseases such as ventricular septal defect and aortic stenosis. Neoplasias can sometimes cause third-degree AV block. HCM in cats can, myocardial infarction, and other things such as digoxin toxicity as well. There are some other weird toxins that can cause a third-degree AV block. There is usually no response to atropine, and permanent pacemaker implantation is required. But we do still always try atropine just in case. The important note on this particular slide is don't ever mistake the slow ventricular escape rhythm for VPCs. So these are slow. As I said, they should be at the most 60 beats per minute if it's in a junctional escape rhythm, and they aren't premature, so they're why the animal is still alive. So suppression of the ventricular escape rhythm with drugs such as lignocaine will result in death. So don't ever do that. Atrial standstill. So the ECG that we show, the heart rate in this ECG is 40 beats per minute, and it's regular. There are no P waves that you can see on this trace, and the QRS complexes are wide and bizarre, consistent with a ventricular escape. So this is atrial standstill. It's characterized by a complete absence of P waves and by a regular escape rhythm, which can be junctional or ventricular, similar to third-degree AV block. Atrial standstill may be temporary, persistent, or terminal. The most common cause of a temporary atrial standstill in dogs and cats is severe hyperkalemia. This is really a sino-ventricular rhythm, as the intracardiac catheterization studies actually show that the SA node is more refractory to the effects of hyperkalemia. So hence the SA node is still actually firing off, and the impulses are transmitted via the intranodal pathways to the ventricles, but the atria are unable to contract, so we don't see a P wave as the atrial myocardium itself can't be activated. Another but less common cause these days is digoxin toxicity. Persistent atrial standstill has most commonly been reported in the English Springer Spaniel due to atrial myopathy. And these dogs develop markedly enlarged paper-thin atria. It can also occur in conjunction with systemic neuromuscular disorders such as muscular dystrophy. The condition isn't responsive to anticholinergic or sympathomimetic drugs, and the only treatment is permanent pacemaker implantation. However, the long-term survival can still be poor due to progressive atrial enlargement, and eventually they'll go into congestive heart failure. So I'll just run through a case example. This is Belle, who's a 7-year-old female spayed border collie. She had a history of 2 weeks of weakness and falling over. During these episodes, she remained conscious, and they only lasted for 1 to 2 seconds before she was back to normal. They weren't associated with exercise, and she was having up to 6 of these episodes a day with no pre or post-ictal signs. On physical exam, her heart rate was 48 beats per minute, and pretty much everything else was within normal limits. So thoracic radiographs were normal, blood work and urinalysis were unremarkable. And these are just her x-rays. So when she was referred to us, she was bright, alert and responsive, and her physical exam was pretty much similar to what the referring vet had found, so a heart rate of 48 beats per minute. There was no murmur, her pulses were strong and synchronous. A basic neuro exam was normal, and abdominal palpation also normal. So these were our differentials that we talked about earlier, cystic sinus syndrome, SA block or SA arrest, sinus bradycardia, obviously, and atrial standstill, and the 3 types of AV block. And I don't think this video, I tried it this morning and it's not going to play. Sorry, guys. I did have a little video loop of her echo, which is pretty unremarkable other than her having a very slow heart rate. So this is her ECG. Does anyone want to have a go at what they think, having a look at this ECG, what they think their diagnosis would be?
I usually pick on Josh, Brooke.
Okay, Josh, you can go.
Sorry.
Thanks.
Sorry, Josh.
No, that's fine. Okay, so I think straight off the bat, looks like there's not a QRS for every P wave.
Yes, good. So I'll give you a hint. It's one of the AV blocks.
Yeah, I'm just trying to remember the 3. So I don't think it's not a 3, because it looks like there are normal. Does look like there is a normal QRS complex there.
Yep. And they seem to be associated with each other.
Yeah.
So there is some conduction. Yeah.
Because there is, or they normally have just extended P.
Correct. Yep. So we're now into a form of second degree
type 1 or type 2. So I think I would say it's a second degree Movitz type 2 heart block.
Good try. You're nearly there. It's a 3-to-1.
Or a high grade.
High grade, yeah, it is a high grade second degree AV block. So we are seeing a pattern of either here you've got 3 non-conducted before we get a conducted QRS, and here there's the 4. And gosh, my bad. We're done. Clicked ahead. So it's a 3-to-1 to 4-to-1 high grade second degree AV block. So this is an example of a patient that needs a pacemaker. So the ventricular rate is 40 if you were to use calipers and calculate that, and the atrial rate is regular at 160 beats per minute. So good try though. You kind of got almost there. I think you just got your
Brooke.
type 1 and type 2 muddled up. All right, so treatment wise, so you can use sympathomimetics such as terbutaline, albuterol, and theophylline to stimulate beta receptors in the cardiac muscle at high doses. Anticholinergics such as atropine, glycopyrrolate, and propofanaline, bromide, and where am I at? Oh yeah, so they competitively inhibit acetylcholine and are vagolytic. These medications may help initially in these dogs, but rarely work with high-grade second-degree and third-degree AV block. They sometimes help with sick sinus syndrome. So usually, as I said before, they only last for a little while, and we end up needing to place a pacemaker. So this is a picture of Rita placing a pacemaker in this patient. So initially, I'm not sure how many of you have seen or know much about pacemakers. So we generally place a temporary lead either through the lateral saphenous or right jugular vein into the right ventricle, just under some light sedation. And we start pacing before inducing general anesthesia. And then under fluoroscopic guidance, we place a permanent pacemaker lead into the right ventricle. And this is a picture of the fluoro image. It was a video, but I don't think it's going to play either. My silly video isn't working. But you have to believe me, that is screwed into the right ventricle, and that lead is attached to the pacemaker, which is sutured in under the skin. So you can see that on this X-ray, it's coming out, around the jugular, and then under the skin, the pacemaker is attached there. And this is just an example of this patient's ECG after having a pacemaker implanted. So when we see a paced rhythm, there is, again, going to be no association between the P waves and the QRS complexes. And we see these monomorphic, regular, wide, bizarre QRS complexes. They're upright in leads, in this particular one, in leads 1, 2, and AVF. They can be positive or negative in lead 3, consistent with a right ventricular origin. And these are conducted at a regular rate. We normally set our pacemakers to 80 to 100 beats per minute. And this is consistent with a right ventricular paced rhythm. And in this example, there are no pauses or non-conducted pacing spikes seen. So this is what you'll see if you ever assess a patient that has a pacemaker and you run an ECG on them. The next case example is Poppy. She's a 5-year-old female spayed chow. She had a 4-week history of lethargy and stopping on walks. The ref vet exam found a heart rate of 60 and an irregular rhythm. She had some blood work performed, which was unremarkable, and she was referred.
Brooke?
Yeah.
Brooke, sorry to interrupt. I should have at the beginning, the people who are in on the call need to be at rounds at 9 o'clock sharp. So we'll wrap you up in a couple of minutes if that's okay.
That's fine. Sorry. I can skip it ahead with her. I can try to skip through these a little bit quicker. So this is an example of second-degree AV block, morbus type 1. So this example shows a progressively elongated PR interval until we find a P wave that's blocked. So causes of that are increased vagal tone or conduction system disease, and how we differentiate between the two is an atropine response test, which this patient responded very well to. So this is her ECG post-atropine with a heart rate of 200 beats per minute that's nice and regular, so a sinus tachycardia. So she has a second-degree AV block due to high vagal tone. And these are some of the differentials you have for high vagal tone, so neuro disease, respiratory disease, and so forth. In this particular patient, we searched really hard for a cause of high vagal tone and didn't find any after doing abdominal ultrasound, blood and urine tests, thoracic radiographs, and so forth. So she was treated with propanthyline bromide, which is an oral anticholinergic with similar effects to atropine, monitored for years, and her signs never progressed. So we'll just quickly rush through some tachycardias. I might skip sinus tachycardia. I think all of you guys should probably be familiar with this rhythm on an ECG. And I might just go through an example of atrial premature contraction, which is the yellow beat that's highlighted there. That's quite a common finding for us to see on an ECG, and they're not necessarily always pathological. The premature contractions when they're atrial are a similar morphology to sinus complexes, but they look to proceed a lot, they come in quite a bit earlier. So this example, the highlighted yellow one, is coming in at an instantaneous rate of 215 beats per minute, while the normal heart rate of the rest of the trace is 100 beats per minute. This is an example of supraventricular tachycardia. So the heart rate in this example is 320 beats per minute. It's quite regular. The complexes appear a little bit wide, but when you measure them with calipers, they're actually normal at 0.04. So this is an example of SVT, a rapid regular rhythm originating from an atrial or junctional focus. And as for single APCs, they should be similar, if not identical, to sinus complexes. The two main mechanisms for SVT are an ectopic focus and a reentrant pathway. And we actually did an ablation this weekend on a dog that had a reentrant pathway, so it's quite exciting that we had that done successfully. Rates of SVT can be over 300 beats per minute with a sustained tachycardia at a fast rate, and it's an emergency treatment is required. You can do things like vagal maneuvers, such as ocular pressure, carotid sinus massage, or dunking the head in water. And I have seen a vet do a Thurn thump as well over the heart to try to induce ventricular defibrillation. It can result in ventricular defibrillation, and when we did the thump on our patient, it did not work. Long-term treatment includes medications like diltiazem and beta blockers, so Soltol, for example, and or digoxin. And if there is a reentrant pathway, ablation like we performed on the weekend is the treatment option that is best pursued. I might just skip ahead.
Brooke,
yeah,
we can kind of sign off a couple of people, and then if you're happy to finish the presentation at normal speed, and record it, they can go back and then record
and
it.
listen to the rest. Okay, yeah, that sounds fine. Oh,
is that okay?
Yeah,
right, I'm gonna.
Thank you so much, Brooke. That was amazing.
Awesome.
Thank you.
Thanks
so much, Brooke.
I'll finish talking to myself.
Awesome. I'll leave you with Brooke if you don't mind. Is that okay?
Awesome. So I might then just flick back. So there we go. Where do I say? All right. So in general, if there's an ectopic focus that will speed up and slow down gradually when there's a re-entry pathway that starts and stops suddenly. So it's incredibly regular and it will break with a P wave. In this example, the paper speeds at 25 millimeters per second, and there is a normal sinus rhythm that you can see here. Which is suddenly turns into a regular SVT here at 240 beats per minute. Well, you can't see the break. It did stop suddenly with a blocked P wave, which is suggestive of a reentrant pathway. And the reason why it's important to run a long trace and see whether or not this rhythm is starting and stopping is to help decide which drugs to use. When we see the sudden starting and stopping mechanism of SVT, ablation may be an appropriate treatment if it's a reentrant pathway. that we're concerned about. So the other question I have for Josh isn't here anymore, but I just want to know if anyone knows what this fourth complex along the trace is. Does anyone have any ideas what this might be?
There's no P wave in front of it, and it's not wide and bizarre, but it is sort of a reverse polarization to the atrial or the junctional. So maybe it's coming from the ventricle.
Yeah, that's what I would have thought. And Rita used to trick me with this all the time. It's this is why it's really important to look at all the different leads and to have all the different leads. So this isn't present in lead 1. So it's in all of the leads except here. You can't see it at all. So this is actually the dog moving the left hind leg. This is the limb that's not involved in lead 1. So that's why you can see it in all.
Right.
Yeah. So I just thought I'd point that out to people, because often people will look at that, and I certainly did all the time. I could see it in most of them, and I was like, oh, what is going on here? Particularly if it's happening quite often, and not just the one time. So that is just movement of that leg that's created that there, but we're not seeing it in lead 1, and that tells us that it was probably the left leg that was kicking, because that's the one lead that's not involved in lead 1. So it's a bit of a trick question, but was something that I learnt and I thought would be interesting to share with everybody.
Definitely.
Yeah. So that's our normal sinus rhythm and SVT. So the next slide is an example of an ECG that is atrial flutter. So the ventricular rate in this patient is 240 beats per minute, and at times it does appear to be regular. There are distinct P waves are not visible, but we do get the impression that they may appear in the ST segment. So for atrial fibrillation, IV verapamil dose, I think, was given, which slowed the conduction through the AV node for a short period. And when we do that, we can typically see the sword-tooth appearance to the P waves called F waves. The rate for flutter waves is 600 beats per minute in this example. So that's the PP interval or FF interval that is calculated and is bordering on atrial fib. So for atrial flutter, the F wave is rapid and a regular atrial rhythm with rates of 300 to 600 beats per minute, whereas atrial fibrillation is greater than 600 beats per minute. So that's how you can tell the difference between the two, is using, again, your calipers to measure that rate. The ventricular rate and rhythm depend on the atrial rate and the state of AV conduction. With atrial flutter, there's anywhere between 2:1 to 5:1 block. The cause of atrial flutter is usually atrial enlargement, and it's treated the same as SVT, so similar drugs, diltiazem, digoxin, and various beta blockers. You could consider electrical cardioversion, so delivering a specifically timed electrical shock to the heart to restore normal sinus rhythm, but it is most useful if animals don't have underlying structural heart disease. So if they have atrial flutter, for example, in horses or giant breed dogs, that's just idiopathic rather than secondary to severe heart enlargement. And this is an example of atrial fibrillation. So in this ECG, the heart rate is 220. It's irregular. We can't see any P waves that are visible, and the complexes are wide, so measuring 0.08 seconds. The diagnosis for this is atrial fibrillation with left bundle branch block, and I'm going to go through bundle branch block in a minute, likely due to left ventricular enlargement. The atrial fibrillation occurs due to severely diseased atrial myocardium generally, And as I mentioned before, the atrial rates are greater than 600 beats per minute, with P waves are being replaced by these F or fibrillation waves. The ventricular rate depends a little bit on the rate of conduction through the AV node, and is usually completely irregular. So very rapid ventricular rates are often seen, and this irregularity can be difficult to recognize without careful scrutiny when it is very fast. When you look at a dog's heart in atrial fibrillation while you're doing an echocardiogram, you sort of see rapid circus movement of the atria that is completely asynchronous to the ventricular rate, and it's quite scary to see. People, horses, and some giant breeds of dogs can develop lone atrial fibrillation. Oops. And this atrial fibrillation is without an obviously enlarged or diseased atrium. The majority of the dogs that we see have severe underlying heart disease. So they have a large left atrium, and our treatment aim is to slow the ventricular rate. So it's rate control, not to try to convert them back to sinus rhythm, which is rhythm control. So slowing the ventricular response rate is achieved through drugs that slow the conduction through the AV node. So generally calcium channel blockers, beta blockers, or digoxin. Our drug of choice in dogs is diltiazem, and in cats is atenolol. This is just a picture of Rita performing an electrical cardioversion in a dog that had lone atrial fibrillation. So a large breed dog, this is an Irish Wolfhound. So it is specifically timed electrical shock, and can actually, in dogs that don't have a heart enlargement as the cause of their AF, convert them back to a normal sinus rhythm. And this was a horse that had the same problem. So they're usually quite uncommon that you have to do them in little breed dogs, but horses and large breed dogs can be converted, which is exciting. The next rhythm is a ventricular premature contraction. So these are premature impulses arising from below the AV node in the ventricular tissue. These impulses don't travel through the conduction tissue of the heart, but they travel through the ordinary cardiac muscle. Transmission of electrical activity is slower, resulting in these typical wide and bizarre configuration. There's my mouse. That is classic for these complexes. VPCs are not preceded by a P wave, and there is an AV dissociation. So VPCs are followed by a compensatory pause. The ectopic impulses usually cannot penetrate the AV node, and they travel retrograde into the atria, hence the normal sinus rhythm continues undisturbed. There are many different causes of VPCs in dogs and cats, including myocardial disease, congestive heart failure, myocardial infarction, neoplasia, pericardial disease, and cardiomyopathy. There are also a lot of non-cardiac causes, including hypoxia, anemia, uremia, sepsis, GDV, pancreatic disease, splenic disease, excitement, stress, and drugs such as atropine, digoxin, anesthetic agents, and adrenaline. Unifocal VPCs, so in other words, all of them having the same configuration at a rate of less than 180 beats per minute, is generally considered an idioventricular rhythm, so not of malignant nature and often secondary to another cause. And these do not require treatment. Indicators of malignancy with ventricular arrhythmias include multifocal forms, R-on-T phenomenon, which is the superimposition of an ectopic beat on the T wave of the preceding beat, greater than 2,000 VPCs per 24 hour, and that's something you determine if you have a 24-hour Holter monitor on your patient. Runs or couplets at rates of 200 beats per minute. And treatment is first addressing the underlying cause. So for primary cardiac arrhythmias, Oral options are pretty much limited these days to mixilotine or sotalol. All right, ventricular tachycardia. So sustained ventricular tachycardia at a rate of 240 beats per minute is shown in this picture. The paper speed's at 25 millimeters per second. If we were to see this arrhythmia, we would treat as follows in this particular order that I'm going to go through until it breaks. Remembering that sustained ventricular tachycardia, even when you get one sinus beat, it's considered a response when you're using short-acting drugs such as lignocaine and esmolol. So if we were to see this, we would start with a lignocaine bolus IV. The published dose is 2 to 4 mg per kg slow IV with a total dose of up to 8 mg per kg. Reader would generally draw up 4 mg per kg, and if the rhythm breaks after 2 mg per kg, then great. Otherwise, she'd give the rest, so the total 4 mg per kg over 30 to 60 seconds. And if there's no response, then she'd give it again, so that a total of 8 mg per kg. If there's been some response, so even just one sinus beat considered to be a response, then she'd go immediately to a CRI. The half-life of lignocaine is only 20 minutes, so she doesn't recommend going too long to get your CRI sorted, as your blood levels will drop back to a negligible level. So the published doses for the CRIs are 50 to 90 micrograms per kilo per minute. We usually start around 75 micrograms per kilo per minute and then titrate up and down from there. A lot of, I think, emergency vets we've seen sort of starting them at the lower end of the dose. Reader tends to go to that higher sort of 75 to begin with and go from there rather than starting at the low end. This is a life-threatening arrhythmia. If it hasn't worked, she'll usually keep going and add in a magnesium bolus. And this is acting as a membrane stabilizer and usually breaks the VTAC, but it might not be long lasting. So the dose to use is 0.5 gram for a small dog, 1 gram for a medium dog, and 1.5 grams for a large dog. And then if all of those things haven't worked, the next step would be a beta blocker. She prefers to check the systolic function with an echo prior to starting a beta blocker. This is so to make sure that the dog doesn't have severe DCM, as a beta blocker is a negative inotropic inotrope and could precipitate the patient into congestive heart failure. So if short-acting choices, either sotalol or esmolol, in the emergency situation where you don't have access to echocardiographic assessment of systolic function, esmolol is a safer drug due to a shorter half-life. As we can check the echo first, we generally actually give of the 2 previous drugs. So we've had good success with this. And then if nothing else has worked, she stops the previous drugs and gives IV amiodarone, so that's a class 3 potassium channel blocker with good efficiency for ventricular tachycardia, but many side effects, including hypertensive shock and cutaneous problems if it's given subcutaneously as well. I think to the skin can also impact the liver and have pulmonary side effects. So it's our sort of last line. And then final step, if none of the above have worked, is electrical cardioversion, generally only used if it's felt the animal is in dire straits and cardiac arrest is imminent. So this is case example, If, who's a 10-year-old male castrated boxer presenting for multiple fainting episodes per day. On examination at his regular vet, his heart rate was greater than 300, and his ECG showed ventricular tachycardia with a heart rate of 240. He was treated with 2 mg per kg of lignocaine IV overnight at the regular vet, and the next morning was started on 40 milligrams of sotalol and referred. When he presented to us at SASH, Biff was bright and alert. The heart rate was down to 120 beats per minute and was irregular. And you can see there are some still some VPCs happening, but no in couplets and singularly, but no ventricular tachycardia anymore. The echo was unremarkable, no evidence of DCM. Blood work and blood pressure are unremarkable. And so his salt low dose was increased to 80 milligrams twice a day. And he was fitted with a 24-hour Holter monitor, which recorded his heart rate and rhythm for 24 hours. After the Holter was removed, he had another collapsing episode, and the Holter monitor, when we reviewed it, showed many runs still of ventricular tachycardia greater than 300 beats per minute. So his salt low dose was increased to 120 milligrams twice a day. And to my knowledge, he's now doing well with no further collapse episodes that are noted. The next case example is a Weimaraner called Cooper, 12-year-old male intact. He was diagnosed with a heart murmur 2 years prior to presentation, and an echocardiogram revealed he had MMVD with some mild mitral and tricuspid regurgitation. But at the time he had no heart enlargement and no treatment was recommended, just yearly rechecks that were advised. He represented 2 years later with hind limb weakness, coughing, increased respiratory effort and rapid irregular heart rhythm. And this is an example of atrial fibrillation with left bundle branch block. His echo showed a marked cardiomegaly by that point with severe mitral regurgitation, and he was in congestive heart failure on his thoracic radiographs. And so he was treated with furosemide for his congestive heart failure, pemobendin and benazepril, and was commenced on diltiazem for his atrial fibrillation. And I think did well for about 6 months and died in his sleep. So we'll do a few more. I'm going to just move on to this example here. So this ECG at first glance, the arrhythmia looks like a run of ventricular premature contractions. And we have been sent cases of dogs that were suspected to have a accelerated idioventricular rhythm or VTAC that ended up being this particular condition. So if you take a closer look at this ECG, there are, and I've highlighted them, actually P waves prior to the QRS complexes. So that with a normal PR interval, if you were to measure that, and this tells us that each complex has originated from the sinoatrial node. These aren't originating from the ventricle, which means that there is a delay in the conduction, which is what's causing the wide and bizarre appearing QRS complexes. As the complexes have deep S waves in the visible 3 leads, this is most consistent with a right bundle branch block. Right bundle branch block is a delay in a block of in the conduction of the right bundle branch of the heart's electrical system. And I'll just talk about that there. So we'll quickly review the heart's electrical pathway, the conduction system with the SA node, intranodal pathways, AV node, bundle of His, and the right and left bundle branches spreading into the Purkinje system. When we have complete right bundle branch block, no electrical activity with the little blue X there goes through the right bundle branch. So the right ventricle is stimulated by electrical activity that passes from myocyte to myocyte rather than through the bundle branch, which originates from the left ventricle, as the electrical activity doesn't pass through that pathway. So the sequence of conduction in the right bundle branch block is the left ventricular activation is activated by the left bundle, so that black arrow. Then we get septal depolarization, which is the yellow arrow spreading from the left ventricle to the right ventricle, which spreads across the septum. And then the resultant depolarization vector is that red arrow. So normal depolarization goes down. Both in this particular condition, we get just activation of the left that then spreads across to the right. So it's changing the axis, and it's also slowing the conduction, which is why we get the complexes that we see in the previous slide. So the QRS complexes are wider than usual, and there is a right axis deviation present with deep S waves in leads 1, 2, 3 and AVF. When you get a partial right bundle branch block, you get deep S waves seen, but the complexes may not be as wide, so they may measure less than normal for a dog. This example is atrial fibrillation with right bundle branch blocks. So this is 6-lead ECG. You can see leads 1, 2, 3, AVR and AVF and AVL. When you take a closer look at the rhythm strip in lead 2 at the bottom, the wide QRS complexes of right bundle branch block morphology with deep S waves. The rhythm itself is regularly irregular, and there are no visible P waves. So this is a diagnosis, as I said, of atrial fibrillation with right bundle branch block. And it's usually seen with conditions like severe tricuspid valve dysplasia with severe tricuspid regurg, severe right atrial enlargement, and right ventricular enlargement can result in that type of arrhythmia. And this is an example of AF with left bundle branch block. So again, it's a 6-lead ECG. We have wide complexes. They're positive in leads 1, 2, 3 and AVR. We don't see any P waves. They're irregularly irregular. Some people may look at this and think that it's ventricular tachycardia. So it is important to go through it slowly. With left bundle branch block, there's a delay in the conduction through the left bundle branch, so the opposite to the right. This can either be the main branch or the anterior posterior fascicles, which I'll show you in the next slide. In this case was a Doberman with DCM and congestive heart failure, and the left bundle branch block was due to left ventricular enlargement. So in left bundle branch block, the left branch is actually larger than the right side with the division into the anterior and posterior fascicles. It can occur, as I said, proximally at the main branch or more further down as it branches into the fascicles. In left bundle branch block, sinus impulse activates the atria, moves through the AV node. Sorry, my mouse is not working, and bundle of His as normal. And then there's a delay in the impulse going through the left bundle branch. So it goes through the right bundle branch first and then across to the left via the septum that you can see. Oh, there's my mouse in the diagram. This is just an example here of small QRS complexes / electrical alterans. So the amplitude of QRS complexes, they have a wide normal range depending on the age and breed of the dog. An amplitude of less than 0.5 millivolts is considered small for most dogs and cats. Most dogs and cats normally have quite small complexes, so it's quite difficult to recognize this in a cat. The amplitude of the complexes can be affected by many factors other than cardiac disease. For example, the distance of the heart from the recording electrode can have a major effect on the amplitude. And things like obesity, the presence of thoracic masses and pleural effusion can also impact the size of your QRS complexes. In this example, there's a condition called electrical alterans, so alternating variation of amplitude in the complexes. So you can see big ones and then smaller ones and then bigger ones and then smaller ones, which is pathognomonic for a pericardial effusion. So if you see this, it's probably a good idea to put your ultrasound probe on and check the patient for a pericardial effusion. And I think this is one of the last slides, guys. So this is just an example of a little smoodle who was referred for an irregular rhythm. His ECG showed a heart rate of 150. And as you can see, there's Following each sinus beat, there seems to be a pattern of a premature contraction, followed by a sinus beat, followed by a premature contraction. So this is an example of atrial bigeminy. The term bigeminy just means every other beat, or following every sinus beat, there's an atrial premature contraction. If it was every third beat, then it would be called atrial trigeminy, for example. In this patient, we placed a 24-hour Holter, and 25% of the beats were APC. So he was started on diltiazem and is doing well and only getting occasional APCs at the moment. So if you do see an ECG with just one or so single atrial premature contractions, it's not usually, of course, a concern, but when we're seeing bigeminy such as this, it certainly warrants further investigation. And this is just a quick example of third-degree AV block in a cat. So cat ECGs, like I said, are really difficult to interpret. I prefer not to use any form of pattern recognition, as it's really easy to get it wrong. I always sit down with calipers and analyze a cat ECG in a methodological manner. This is a cat who was 16 years old who presented for one episode of collapse. And in this ECG, in lead 2 and AVF, the easiest to look at, this one and this one. So you can see, obviously, lead 1 is very small and it would be quite difficult to measure. The amplitude we turned up to 20 millimeters per millivolt, from the standard 10, because the feline P waves can be quite small. You can see the ventricular rate is regular, and that's occurring at 80 beats per minute. The atrial rate, if you were to count each individual P wave, is at 160 beats per minute and regular. There appears to be no association between the P waves and the QRS complexes, and they're upright and positive in leads 1, 3, and AVF, and negative in lead 1, suggesting a right axis deviation of unknown cause in this cat. So this is third-degree AV block, and because the rate is 80 beats per minute, there's a junctional escape rhythm that's occurring in this cat. So most cats that have this don't actually need pacemakers. They tend to be okay because they have a faster escape rhythm than other animals. And finally, I tacked this one on at the end because we did see this recently in the clinic in one of our patients who is recovering from the procedure the day before. This is an example of ventricular fibrillation. So it's caused by activation of too many circuits in the heart, and everything's basically firing out of control. It is a fatal arrhythmia. So on ECG, you'll see undulation of the baseline. There are no P waves or QRS complexes. Hemodynamically, it produces circulatory collapse and arrest. So therefore, it's a pre-agonal state leading to death within seconds to minutes. So if you see this, treatment is defibrillation, so electrical shock to the heart. The goal of that is to stop the uncoordinated ventricular contractions by simultaneously trying to transition as many of the myocardial cells as possible into the same refractory period, allowing synchronized electrical activation. Sorry, I'm like choking. Sorry, I just wanted to make one last little point before I finish. So the underlying cause is by definition a severe disorder, and that can be anything from myocardial trauma, anoxia, severe electrolyte disturbance, or advanced states of shock. If ventricular fibrillation is seen on an ECG, artifact must immediately be ruled out, so making sure you've got an appropriate trace between the patient and the ECG leads, as poor connection can mimic ventricular fibrillation. If you see this rhythm, also important to feel for a pulse. Any palpable pulse essentially rules out ventricular fibrillation. So if you can feel a pulse, it is not ventricular fibrillation. and the patient would also be unconscious. So because BF is inconsistent with adequate cerebral perfusion, if your patient is looking up at you and you see this sort of trace, it's probably artifact. It is artifact because cerebral perfusion is compromised. So these patients are about to die. They should be pulseless and they should be unconscious. And it's very fun doing it, but it's not very rewarding. Unfortunately, our patient who did develop VFib did sadly pass away. So yeah, that is everything from me. I'm sorry I've gone for so long, guys. I think I tried to squeeze in way too much for the hour than expected last night. So I'm sorry. And I think most of you will probably just watch this back later. Thanks.
Great. Thanks so much, Brooke.
No worries.
Bye.
Yeah. Bye.